Good evening, everyone, and thank you for joining us for tonight's Woo You event with Dr. Justin Schweitzer, and he's going to be talking about optimizing the ocular surface in glaucoma. I'm your host tonight. My name is Dr. Ariel Sorenzi. I'm super excited to introduce our speaker, Dr. Justin Schweitzer. He was born and raised in Jamestown, North Dakota, and attended Jamestown College and graduated with degrees in biology and business administration in 2002. He then attended the Pacific University College of Optometry, where he graduated summa cum laude in 2006. After graduation, him and his wife, Nissa, moved to Sioux Falls, where Dr. Schweitzer enjoyed a great general practice. And in July of 2013, he completed his fellowship training in advanced anterior segment surgery care and pathology at Advanced Thompson Vision. Dr. Schweitzer is a member of the American Optometric Association, American Academy of Optometry, Scleral Lens Education Society, and the South Dakota Optometric Association, and has had multiple articles published in scientific journals. And we can't get enough of him at Woo U. So this is, what you said, the third or fourth time?
I think the third. I think it's the third.
The third. Okay. Well, we're going to get you a t-shirt because
I love it.
Yeah, you're the resident. But here are his financial disclosures, all of which have been mitigated, and we're excited to hear from you now.
Thank you so much for the introduction again, and all three of them. It's been you and I, so we've done the show together, and it's been fun. It's an honor to be back at Woo U again, and I want to thank everyone for taking their time tonight to be with me. I know it's never easy after a long day in clinic and a long day seeing patients to say, hey, I'm going to get another hour of education and think about eyes for another hour. But I'm excited to be here. I'm excited to talk about this particular topic, which is, our glaucoma patient population and how much their ocular surface really does matter. And I will tell you, and you'll hear me say this probably multiple times, that if you are managing glaucoma patients or you have a glaucoma clinic, you also have a dry eye clinic. It goes hand in hand. And so managing patients with glaucoma, you got to be able to manage the ocular surface as well. And I think the other thing that you'll find out tonight is we have a lot of good treatments for dry eye. And a term that I want you to kind of think about as we're moving through some of the treatment options as we manage patients, that have glaucoma and have ocular surface diseases is ocular sparing. And we think about a lot of things out there, right? Our glaucoma patients are on a lot of drops. Typically, we're trying to minimize those drops. And I'm going to talk through some solutions of how do we minimize the drop burden for these patients. And I'll back that up with some science. And if we can minimize that drop burden, if we're going to treat that ocular surface, is there an issue with adding other ocular surface drops that's going to affect compliance? And so I do think we have to consider treating our glaucoma patients' dry eye differently than we treat a traditional dry eye patient that doesn't have glaucoma. And I'll get into that as we kind of talk through what are some options. Sometimes it's these in-office therapies. Sometimes it's things that are ocular sparing, and we'll touch on that as we go. And I still will touch on some things that can help our glaucoma patients that may involve having to use drops. And then we'll definitely talk about what are some different treatment options that can minimize drops for our patients as well. And so that's kind of an overview of what we're going to talk about this evening. So here's a patient of mine, the longtime glaucoma patient. You can see his complaints over there on the right. His eyes are red. His vision fluctuates daily. He mentions, boy, I miss my drops on a pretty consistent basis. I do it off and on. I'll tell you right now, this is a patient that's not progressing on me. His visual fields are stable. His optic nerve head is stable. His OCT is stable. He's got good intraocular pressure. But I would ask all of you, would you consider this patient a controlled glaucoma patient? He talks about it with me that, boy, yeah, I'm great with my pressures. I'm glad everything's stable, but look at my eyes. My friends talk to me about my eyes. You can see how red, irritated, uncomfortable he is. And so I would argue that this is not a controlled glaucoma patient. Yes, our job is to make sure that our patients don't go blind from glaucoma. But as you see, and as we get into this, our other job with these patients is to make sure that they're living a good life. They got to have a good quality of life. They can't be dumping drops in their eyes, 3, 4 drops, and be living life with eyes like this because he's not seeing the way that he wants to. Yeah, his disease is stable, but he's not controlled. And so when we define controlled glaucoma, yes, we want intraocular pressure that's stable or at our target. We want visual fields that are not changing. We want the nerve to be stable, and we want the OCT to be stable. But we also need to take into account that quality of life. We need to take into account, is their vision fluctuating? Are they tolerating their drops? As you'll see in a little bit when I talk about studies, if they're not tolerating their drops, they're very likely progressing on us as well. Are they having trouble with stinging, burning? Because this to me is not a controlled glaucoma patient. So throughout this lecture, I want you to think about, what is the controlled glaucoma patient? Yes, it's IOP, visual field, OCT, that all needs to be controlled, but we have to put in that quality of life piece as well when we're managing these types of patients. So a really quick case, kind of to set the table. This was a patient of mine, 71-year-old, that came in for, an opinion on his glaucoma and his irritated eyes. You could see his vision's 20/20 +1. And so visually, he's doing really, really well. T-max was 29. He's been placed on a prostaglandin analog once a day in both eyes. He's been on that for an extended period of time. He's on a fixed combination agent as well, twice a day in both eyes. You can see his intraocular pressure, 19 and 18. And, so from 29 down to 19 and 18, that makes me feel pretty good. I'm saying, all right, that's a big drop. He's sitting okay there. It's the first time I've seen him, so I don't know for sure if he's stable, but I don't mind seeing that kind of pressure reduction. That looks good. You can see his cup to disc ratio. He's got thin corneas. He's got a low corneal hysteresis. Gonioscopy is open to ciliary body. And we'll look at the slit lamp fields and OCTs here in a minute. So overall picture, just based on this, I'm thinking, okay, there's some risk here. He's already being treated. He's got thin corneas. He's got a low corneal hysteresis, but at least from his T-max of 29, he's down to 19 and 18. Then we look at the slit lamp exam, and this was bilaterally the way that his corneas looked. And we all would agree that there's some central SPK present. Automatically to me means there's inflammation there. Is it from the drops? Is it from, other dryness? Is it from allergies? I don't know. What I do know is that there's inflammation there, and likely it's coming from this long-term use of drops. And so I want to at least manage this. Here's his OCTs, right and left. You can see in the right eye, he's got some temporal thinning, an inferior ganglion cell defect as well. And in the left eye, he's got some early temporal thinning, but there is some temporal thinning on the OCT. And then here's his visual fields. Left eye on your left side there, right eye on the right side. And if we back up, it matches fairly well with structure and function. The left OCT, borderline, yes, some temporal thinning there. Not a lot right at the edge. And the field's clean. It looks normal. We could argue maybe there's an early nasal step there, but it looks very clean. The right eye, a little bit of a different story. We look here at the OCT. He's got significant temporal thinning. He's got that inferior ganglion cell defect, which is showing up right here. And when we look at the visual field, we have this kind of paracentral defect that is very concerning to me. Now, again, I don't know if that's new. I don't know if he's progressing. We're going to have to repeat these measurements and repeat these tests because, again, the first time I've seen him, I'm going off of what the T-max was. I'm going off of where his current pressures is. Is it low enough? Maybe, maybe not. But I want to address his ocular surface, his irritated eyes. I was shocked that he was seeing 20/20 based on the clinical picture, not from the visual field, but the way that his cornea looked. So a couple considerations in this case. Number one, do we need to address the ocular surface? And I would argue we do. We have to address the ocular surface for this patient. It's one of the main reasons he came in. He even stated in his chief complaint. So if I ignore the ocular surface, I'm not doing what he asked me to do or what one of his complaints are. And then we need to think about his glaucoma therapy as well, managing his glaucoma. So here's what I did. We performed a drug delivery procedure in the clinic called Bimatoprost SR, and I'll get into that tonight, in both eyes, the right and the left eye. We typically space those a week apart. So we did the right eye and a week later brought him back, did the left eye. I added a soft steroid for 2 weeks, 4 times a day, because anytime that I see corneal staining, that means there's inflammation present, and I can put him on a quick soft steroid 4 times a day for 2 weeks. I'm not worried about his intraocular pressure in those 2 weeks with a soft steroid. Very comfortable with doing that, even in a glaucoma patient, knowing that I'm going to see him back fairly quickly anyways. And then I went ahead and stopped all his glaucoma medications because we have the drug delivery device in the eye. I call it a drop holiday, just giving him a short break. This is not a long-term solution. This is a solution to get his ocular surface cleaned up, and then we'll see how he's doing. You can see his intraocular pressure dropped to 16 in both eyes at a 6-week post-op check. Does that mean that Bimatoprost SR pellet was more effective than the PGA and the combo agent he was on? No. I would not argue that. I don't think it is more effective. What I would argue is he probably wasn't taking his medications the way that he should. And just that pellet being inside the eye, forcing medication in his eye, he didn't have a choice, probably controlled his intraocular pressure. His corneas looked much better. And then at that follow-up visit, I went ahead and placed plugs. And we're going to consider putting him, or I did put him actually on an immunomodulator twice a day. And I'm continually monitoring this patient at an every 4-month interval. And if his pressures or his visual field or his OCT changes on me, then I will go ahead and we will manage him in a way that we need to. And that's probably going to involve adding something back from a medication standpoint. It may involve doing a selective laser trabeculoplasty, but I'm always thinking of ways, how do I make sure that we don't get back to where we were, which is multiple medications on the surface for this patient that's probably irritating his eye? Could we do a preservative-free latanoprost? Yes. Could we do SLT? Yes. Unfortunately, right now, we can't do another bimatoprost SR. We can just do one, and I'll dive into that a little bit here in a minute. So that kind of sets the table of what we're going to talk about through the rest of the evening. I do want to briefly touch on doing an ocular surface disease assessment. And I know many of you manage dry eye in your practices, but there may be a few of you on here that say, boy, when I hear a dry eye talk, I feel so overwhelmed because there's all this technology that I have to use in order to manage a patient with dry eye, to diagnose a patient with dry eye. And I'm here to tell you that you don't need a ton of technology. It's nice to have it, and I'll get into that, but it's really nice to be able to say, guess what? You need 4 things to really start managing dry eye. Number one, I would argue you need a questionnaire. They're extremely helpful because if you have a questionnaire, in this example, we have a speed questionnaire, your patients will then be able to tell you that they're having problems. This questionnaire will drive the conversation. And remember, 50% of our patients will complain of ocular surface disease issues, but 50% of the time they won't. And so a questionnaire doesn't solve all the problems, but it's a good way to get the conversation started. Number 2, you got to have a slit lamp. I think everyone that is on this call, that is on this talk tonight, probably has a slit lamp. Number 3, sodium, or you need our vital dyes. So, fluorescein, lissamine green, to be able to look at tear breakup time, to be able to look at corneal staining, the tear meniscus. A very simple thing to have in your clinic to be able to learn a lot about what's going on with the eye. And then the last thing would be a digit, a finger, to be able to press on the glands, to be able to identify meibomian gland dysfunction, to look at the meibum, look at the color of the meibum, to see if you need to manage MGD. And we'll talk about MGD in our glaucoma patients here in a little bit, since we're talking about glaucoma. But if you have those 4 things, I really think you can manage your patients. And so from the ASCRS dry eye algorithm, we want to look, lift, pull, and push. And then I'm going to add one called look down, because in a little bit, we're going to talk a little bit about the prevalence of blepharitis, specifically Demodex blepharitis, in our glaucoma patient population as well. Once you do these 4 things and you start to fall in love with treating ocular surface disease, you can add other pieces to your arsenal. And are these things necessary? I wouldn't say they're necessary, but they're very helpful. Osmolarity testing. Meibography, more for me, is an educational tool. It's nice to have to look at structure, but educational wise, it's great. And then MMP9 testing to look for inflammation. Again, not something you have to have immediately, but great technologies to consider. And we know with osmolarity that normal is somewhere between 280 to 295. If we see above or equal to 308, that means there's an abnormal hyperosmolar, or the homeostasis of the tear film is being affected. And greater than 8 between the 2 eyes. So if one measures normal and the other one measures a little higher, they both measure normal, but there's a difference of 8, that's also considered abnormal. And so we have some insufficiency with the tear film. I mentioned MMP9, and then even cameras, taking images to educate patients could be useful at some point in time. But remember, this is your starting point. Dive in with this. You can always add these as you move forward with managing these particular patients. So glaucoma therapy in the ocular surface. So I'm not going to beat up BAK a ton, but I think we need to talk about BAK, which is the preservative that's in a lot of our glaucoma medications. And BAK serves a purpose. It allows the medication to get where it needs to get to help lower intraocular pressure. The problem with BAK is when you stack BAK med on top of BAK med on top of BAK med, you start running into ocular surface disease issues. So is one okay? Probably, but when you start stacking them on top of each other, that's when you start running into a variety of different issues. This was an animal study looking at neurotoxicity of BAK. So this wasn't done in humans. And what you're looking at here is exposure to BAK at 0.01% and 0.1% over a 7-day period. You can see in the middle image here, they looked at corneal staining, and the patients that were on BAK after 7 days started to have some corneal staining. Again, an animal study, so these weren't humans. And you can also see the nerve density here in the BAK group at the bottom two here, the nerve density or the nerve plexus regressing or damage being done to the nerves over this period of time with exposure to BAK. It's shown over here on a graph with nerve fiber density on your left, and over here is looking at tear breakup time or aqueous deficiency over time, again, in the BAK group. And so BAK not only beating up the surface a bit in this particular study, but also affecting the nerves that innervate our cornea. And we know that a common cause of neurotrophic keratitis is extended use of topical glaucoma medications with BAK. We also know that BAK disrupts the tear surface. You can see that here. It acts as a detergent. It affects the lipid layer, decreases mucin production. It induces inflammation. Again, the longer the patient is on it and the more they're on, these things traditionally get worse. It can affect the way that glaucoma surgeries work. And we've all seen this in a patient that's on 3 meds that's ready to have a filtering procedure. A lot of surgeons don't want to operate an eye that's red, hot, irritated. And so how do we reduce that inflammation on the surface of the eye? And we'll talk about some solutions here in a minute. And then the dose-dependent piece. I've mentioned this many, many times already. The more that BAK is put on the eye, meaning multiple drops, the harder it's going to be on the surface of the eye as well. We also know, again, that multiple medications equal higher incidence of dry eye disease. And so you can see here, number of drops from 2 different particular studies, 1 drop versus 2 drop versus 3 drops. What happens to the percentage of patients that suffer from ocular surface disease or dry eye disease? The first study being a little smaller at 61 patients, the other study being much, much larger, but both following the same trend. The more drops that are on the eye, the more issues we have with dry eye disease. It affects the meibomian glands too. You'll read some research on this that 90% of our patients that are on PGAs for an extended period of time will have some form of meibomian gland dysfunction. This was a study over 18 months that looked at a variety of different clinical characteristics. What you see in table 3 here are patients that were, number 1, a control group, not on any drops. Group 1 was either on 1 preservative-free drug or 1 preserved drug. Group 2 was on 2 preserved drugs. Group 3 was on 3 preserved drugs, and these were topical glaucoma medications. And what you're seeing here is the ocular surface disease index score, which is climbing significantly depending on the number of drops they're on. Tear breakup time getting worse depending on the number of the drops they're on. Corneal staining getting worse. And then the meibomian scores getting much worse as well over on this right side. This was another study published in 2012 looking at patients over an 8-year period that were on glaucoma medications, traditionally or most commonly prostaglandin analogs, lid margin abnormalities, meibomian gland dropout, very statistically significant in this group, a small study, but still talking about meibomian gland dysfunction. Now, I mentioned earlier, we're going to get into talking about this ocular sparing terminology because with our glaucoma patients, it's hard enough for them to be taking their drop or drops consistently. And so when we think about how do we treat the ocular surface in these patients, should we be adding additional drops? I try to think ocular sparing, but we have some new drops on the market that may be effective and are effective probably for certain types of conditions. And when we think about our glaucoma patient population, I mentioned, there's studies that have shown 90% of patients that are on a PGA have some sort of MGD. Doesn't mean they have advanced MGD, but they even could have mild or early MGD. A new medication that just came onto the market is this perfluorohexyloctane. It's 100% perfluorohexyloctane. Some of you may have some experience with this. This is really a medication that's indicated for dry eye signs and symptoms. But the way that it works, and I'm showing you an image here, is that it may be ideal for our patients that have evaporative dry eye or meibomian gland dysfunction, which is very prevalent in our glaucoma patient population. And why this probably is effective in evaporative dry eye is just the way that the molecule works. You can see here it has an aerophilic top to it. So this part of the molecule wants to be towards the air. And then it has this lipophilic hydrocarbon segment on the bottom. And you can see how it orients in the tear film on the right side here. You have that aerophilic portion wanting to reach for the air, and that's how it orients there. And you have that lipophilic portion wanting to bury itself in the lipid layer. And so it provides this very nice monolayer on the cornea. And in an animal study, it was shown to be present on the eye for up to 6 hours. And so for our glaucoma patients with evaporative dry eye, could this be a drop we could consider? It's dosed 4 times a day. I think when I think of glaucoma patients, that may be the only disadvantage. Again, speaking just of glaucoma patients, because again, we're trying to minimize how many times they're having to put drops in their eyes. But again, when we think about that high percentage of MGD in that glaucoma patient population, I think this is something that at least needs to be considered. When we look at the clinical trials on this, there's 2 phase 3 clinical trials. We're looking at the pool data from those phase 3 clinical trials. It works quickly. You can see in the blue, that is the perfluorohexyloctane that we just talked about versus a saline control. And you can see how quickly total corneal fluorescein staining improved even by day 15, and the day by 57, it improved even more. And so you're looking at the improvement from baseline is what you're seeing here in this particular study. And then we saw a relief of symptomology as well. And I don't want to spend a ton of time on this. I just want you to be aware of this as an option. Again, day 15, day 57, the blue being the medication that we just discussed, the improvement in the dryness score, the improvement in relief for these patients. So they improved on a questionnaire essentially for more comfort. I think the other thing we have to be aware of is that a lot of our patients suffer from blepharitis, especially our glaucoma patients. This was a study of over 1,000 patients. 57% of these patients had some Demodex blepharitis. And then they looked at just the glaucoma patients. And just in that glaucoma patient population, 65% of patients had Demodex. And so a very simple solution to manage these patients that have ugly looking lids, that have Demodex, that have, redness, irritation, is to treat it. And we now have a medication to treat this as well. And so I would ask that we don't ignore this in our glaucoma patients. This particular medication is FDA approved now. I'll take you down to bullet point number 4 here. It's the first and only one that really targets, paralyzes, and kills the Demodex mites. Typically you prescribe it for 1 course, so twice a day for 6 weeks to manage these types of patients. All right, so now we're going to shift focus to really why should we care about the ocular surface, and then we're going to talk about treatments really involving, the ocular sparing piece and glaucoma treatments that can help reduce that medication usage as well. So I've kind of set the table of talking about, all right, thanks, Justin. We know MGD exists. We know Demodex blepharitis exists. We know it's evaporative dry eye. You beat us over the head with that over and over again. Let's move on. So I'm going to move on. Why should we care? Why should we even care if they have dry eye? Our job is to prevent them from going blind. If we prevent them from going blind, none of the rest matters, right? Well, it does matter because our patients probably are not being compliant if they're suffering from dry eye or they're suffering from ocular surface disease. You can see 2 different studies here looking at compliance rates with glaucoma medications. Patients without dry eye disease symptoms were almost 90% compliant with their medications. Patients with dry eye disease symptoms, 63% compliance. A big difference between the two. And so making sure that our patients are not having dry eye symptomology very likely helps them be more compliant with the medications that they're taking. We also know that glaucoma, more in advanced stages than mild stages, affects contrast sensitivity. So we look at the study on the left, we're looking at normal in the blue, mild, moderate, severe from a glaucoma staging standpoint, and how it affects contrast sensitivity. Our patients with more advanced glaucoma have a decline in contrast sensitivity. So that's going to affect the way that they're functioning on a day-to-day basis. The other study on your right looks at patients with central SPK and patients without central SPK, and then a normal eye with no SPK, and what happens to their contrast sensitivity. And what you're seeing there is with central SPK, contrast sensitivity is affected more than a normal eye. Without central SPK, contrast sensitivity is affected as well. And so you can imagine if we have an advanced glaucoma patient that has ocular surface disease with SPK, that is going to affect the way that they function on a daily basis. It's going to decline their contrast sensitivity fairly significantly. And then finally, if they're not taking their medications because their medications are irritating them, they're going to progress. This is a study looking at patients that had side effects on their topical glaucoma medications. That's in the dark black filled in boxes there. And patients that didn't have side effects, which is in the white clear boxes there. We're looking at progression over time on the visual field. And you can appreciate the gap that begins to form between these two patient types. Now, the group that has no side effects, they still progress over time. And with glaucoma, it's a progressive disease. It's going to change with time if you manage these patients long enough. Our whole goal is how do we slow it way, way down? The patients with side effects, though, look at how rapidly they're progressing over time. And so if we can get them on medications that they can tolerate and make sure that they don't have ocular surface disease symptoms or signs of it, we're very likely doing ourselves and them a favor. It's going to make it easier for us to manage these patients. And we're very likely slowing down progression in these patients over an extended period of time. So let's get into the solutions. We talked about all the background information. How do we manage these patients? What are some options? And I'm going to start first with what are our glaucoma treatment options we can consider in a patient that has ocular surface disease. I think everyone would agree that traditionally when we manage a glaucoma patient, and this is the way I do it as well, when I diagnose someone, I'm going to put them on a prostaglandin analog. That's typically what I'll do, or we're going to do SLT. And I offer every brand new diagnosed glaucoma patient two choices. I say, hey, we can start you on a prostaglandin analog, and I go through the pros, the cons, the benefits of that. And then I talk to them about selective laser trabeculoplasty as well. And we decide what's going to be best for them in their particular scenario. But what about a patient like we just had earlier in that case that has ocular surface disease? Or what if it's a patient that presents, you diagnose glaucoma, and they already have ocular surface disease? Should we just dump BAK on the surface, or should we start thinking strategically long-term how we can preserve that ocular surface? Well, there's some options for that. We have some studies looking at preservative-free formulations. This was a large study, 349 patients. Visit 1, these patients were on preserved glaucoma medications. You can see that here in the percentages of not only symptoms, but also ocular signs from these preserved medications. What they did in the study then is they switched these patients from preserved to non-preserved, and look at the decrease percentage in all these groups from a symptomology standpoint, as well as from a sign standpoint, just from making that switch from preserved to non-preserved. Remember, we have a lot of non-preserved glaucoma medications. We have a non-preserved, combination agent, a COSOP preservative-free. We have, some other non-preserved options out there. There's a brand new non-preserved option on the market, a preservative-free latanoprost that was just launched a few weeks ago. Once a day, like our traditional prostaglandins. And I think the common question is, well, is it as effective as what a branded prostaglandin is, or one that has BAK? And you're looking at 2 phase 3 clinical trials right now. You're seeing a US trial, and something to point out in the US trial is these baseline pressures were very low. And so we wouldn't expect to see a big drop, a big mean IOP reduction when we have this low a baseline pressure in the preservative-free latanoprost group and then the Xalatan group. But what we do see is very equal drops in IOP. They both behaved fairly similarly, and there really wasn't a statistically significant difference. In the European trial, you could see a much higher intraocular pressure, a much higher baseline pressure. So we'd expect a bigger drop, and that's what we saw. We saw a good 30% reduction in IOP, maybe even a little bit more than that. But again, they both behaved similarly. And so talking about that patient I just mentioned, they come in, you diagnose them with glaucoma, they have some ocular surface disease. You're thinking ahead, this would be a consideration to say, I'm just going to initiate a preservative-free prostaglandin, because that's what I've always done anyways. I've always used a prostaglandin, but I'm going to go preservative-free so that I can help your ocular surface and maintain your ocular surface. So a solution to definitely consider. SLT, I think it's something we have to talk about. We have to talk to our patients about it. There's enough data now out there, and I'll go through the light trial with you here in a second, that this is a great option for our patients. Optometrists are doing this in 14 states. It's going to continue to expand over time. It's a great treatment option. It's not a forever treatment option, but if we can buy our patients 3 to 4 years of no medications and then repeat it and buy them another 3 to 4 years of no medications, it's a nice step in the journey of managing our glaucoma patients. And remember, glaucoma is a marathon. There's a lot of these different treatment options we're going to consider. Nothing we offer them is going to last forever. And so SLT, a great option to consider for our patients. A lot of you are familiar with this particular study, the LIGHT trial, a very large study, 760 some patients in it, comparing SLT in one arm to drops in the other arm. Primary outcome being quality of life at 3 years. Probably the most surprising conclusion of the study is that there was no significant difference in quality of life between SLT and drops. What is really significant are some of the secondary outcomes, and I'll take you right to the bottom bullet point there, which is, 78% of patients drop free at 3 years. And so a significant amount of the patients not having to take a drop over that 3-year period. And then I think the 6-year data, which was just recently released, is very important as well. And again, I'm going to take you right down to this bottom bullet point here, that at 6 years, almost 70% of patients that had SLT are drop free at 6 years. So again, the data supporting that we should at least offer or discuss SLT. And if we can buy our patients some time away from drops, that would be ideal. One study that I'm really excited to see here, and this is called the COAST trial. It's not done yet. They're currently enrolling patients in the United States in this particular clinical trial, but this is the rationale for it. So this was done a while ago. They have 10-year data on this. Again, this isn't the current COAST trial. This is the rationale to start the COAST trial, and that's being done right now. It's looking at low energy SLT being repeated annually. The way that this study was set up is each patient or in each arm, some patients got ALT 360 degrees one time. Some got standard SLT 360 degrees as needed. So if they were progressing, getting worse, weren't at target, they got SLT. And then some got low energy SLT 360 degrees repeated annually. Didn't matter if they were getting worse, didn't matter what their pressure was in that low energy group. When they came back every year, they got a little bit of SLT. Didn't matter what was going on. So when we look at the 10-year medication-free rates, you can see low energy SLT, over 50% of these patients not on medications up through that 10-year period versus the ALT and standard SLT group. You look at the medium time to treatment, meaning when did they need to intervene with some other treatment because they weren't at target anymore or they were progressing. You can see in that low energy SLT group, they went 6 years or so without needing a treatment. So that median time to treatment. I'm excited about this because it makes you wonder, what is the future of SLT? Is it going to be these patients come back to see us annually? We do our visual field, we do our OCT, and then we do our annual low energy SLT to treat these patients. And can we minimize some of the drop burden because of that? And we'll wait. We'll see what the COAST trial tells us, but that would be excellent if that's the case, and that is something that would fit into managing our patients. Drug delivery is another hot topic that will continue to gain a lot of steam. Right now, we have one on the market. That's the one I'm going to talk about tonight, which is Bimatoprost SR. The other one that's very close to being approved is this particular one up here, Travoprost intraocular implant. Tonight, we're going to focus on Bimatoprost SR. You may recall earlier that patient that I was managing, I used Bimatoprost SR for that patient. This is a small pellet that's injected into the eye. This can be done at the slit lamp, as you'll see in a video here in a second. It's a 10 microgram Bimatoprost pellet. 10 micrograms is 1 drop of Bimatoprost in this sustained released implant. It releases the medication for about 4 months. Don't let that fool you into thinking that it's only efficacious for 4 months. And I'll show you some data here on that in a second. My favorite way to use this are these patients that need a drop holiday, that I want to manage the ocular surface, because we could put one of these in their eye. I could take them off their medication or medications. I know they're still getting IOP control. I can manage or attack the ocular surface. And then once their pressure starts to go back up, or I start to notice some changes on the OCT or visual field, then I'm able to intervene with something else, maybe SLT, maybe a preservative-free latanoprost. And so my favorite way to use this right now is treating really ocular surface disease, even though it's lower in intraocular pressure. The indication is we can only implant one of these. And so that's probably the unfortunate piece of that is we're only able to implant one. It's a single intracameral administration. It does dissolve. So eventually it will dissolve on its own and go away. It is indicated for any type of open angle glaucoma. And it's indicated for anyone that has healthy cornea. So if they have gutata or they've had a cornea transplant, you don't want to put one of these inside the eye. But any type of open angle glaucoma, pigmentary, exfoliative, anything open angle, it can be utilized or considered. Here's a quick video of how it's done. So this is at the slit lamp again. Patient is slightly dilated. I would recommend not doing it when they're dilated. Give them a couple drops of proparacaine. They'll appreciate you a lot better before you go ahead and use that 28 gauge needle. And so the needle goes in on the temporal side and goes in about 2 bevel lengths. So you'll see now he penetrates, goes in about 2 bevel lengths. And then there's a small actuator button. He'll push that, and there comes the pellet right now. And it will drift down to the inferior angle. You retract the needle, and the procedure is done. Patient gets a betadine wash on the front end, and then we typically put them on an antibiotic for about 4 days. So 3 drops a day of moxifloxacin for 4 days. And then I'll see that patient back 6 weeks later, and we'll manage their intraocular pressure and see how they're doing. So a really nice procedure to get patients off of medications, drop holiday, think of it that way. And you probably have a surgeon in your area, if you can't do it, that can do it. Right now, optometry is only doing that in roughly 4 states. So the majority of that's being done by surgeons, but I am almost sure you could find someone doing that if you wanted that treatment done for one of your particular patients. I mentioned earlier that even though it elutes medication for only 4 months, that the efficacy can last much longer than that. So this was a 24-month phase 1 and 2 clinical trial. And when we look at the 10 microgram group with the bimatoprost pellet went in one eye, the other eye got a drop of topical bimatoprost in this study. The 10 microgram group lowered pressure by about 7.3 millimeters of mercury. The big take home from me on this particular study is this bottom bullet points here. 68% of patients went 6 months without needing to be retreated. 40% of patients went 12 months without needing to be retreated. And over a quarter of the patients went 24 months without needing to be retreated. And so even though it's a eluting medication for only 4 months, it lasts in a lot of patients longer than that. And so you just manage these patients like you would any glaucoma patient. You're going to bring them back for that 4 to 6 week IOP check. If it's a mild glaucoma patient, you're going to watch them probably, twice a year. If it's a moderate patient, you may see them 3 to 4 times a year. And if it's a severe patient, you may see them 4 to 6 times a year. But I don't manage my patients any differently as we put this in the eye. I think of it like a drop. It's eventually going to wear off and you're going to have a solution. But I think of it really like a drop in managing these particular patients. Minimally invasive glaucoma surgeries. I think it's another thing we have to consider. Now, this is a surgical procedure. You want to work with surgeons that are doing different MIGS procedures. We know that a variety of different minimally invasive glaucoma procedures reduces the medication burden, whether it's stents, whether it's goniotomies. We're able to see a reduction in medication usage. And earlier, based on studies that we looked at together here a minute ago, if we can reduce the medication burden, we can make the ocular surface better. I did a study along with a few of my colleagues looking at ocular surface disease and the changes after we implanted a couple or one trabecular microbypass stent. This was a small pilot study of about 50 patients. And this just had never been looked at before. We always assumed that, okay, if you reduce the medication burden by putting a stent in the eye or doing one of these other goniotomies, that we're going to see an improvement in ocular surface disease. We know we get off of meds, as you can see with these studies, but what happens to the ocular surface? And so we had these patients undergo cataract surgery plus a MIGS procedure. They filled out an OSDI on the front end. We looked at corneal staining. We looked at hyperemia. We looked at tear breakup time. And then at 3 months, we had them fill out the OSDI again. And we looked at those findings again: staining, fluorescein breakup time, and hyperemia. What we saw with the ocular surface disease index was a significant improvement. They went from 40.1, which is severe from a symptomology standpoint on the OSDI, down to 17.4, which is mild on the OSDI. Almost normal on a symptomology standpoint. And again, that's from pre-op to 3 months. These patients were on 1.5 glaucoma medications preoperatively, and at 3 months, they were on a half a medication. So we reduced their medication burden by about 1 by doing one of these MIGS procedures. We also saw a significant reduction in corneal staining going from 1.4 down to 0.4. We also saw a significant improvement in tear breakup time going from 4.3 up to 6.4. So this was the first of a kind study that looked at quality of life with MIGS procedures. Now, the iStent Inject FDA clinical trial looked at this over a longer period of time, up to 2 years, and showed very similar types of results. I think the weakness of this study, and I'll speak to the weakness of my own study, is that it's too short. It was only 3 months. And we really need a longer study to look at these parameters because we know, as I mentioned earlier, that glaucoma is progressive. It's going to get worse with time. And very likely these patients that are in this study are going to need something added back at some point in their glaucoma marathon journey. And when we have to add something back, these parameters that we looked at will very likely start to get a bit worse again. Doesn't take away from the fact that we know by reducing the medication burden with the MIGS procedure, we're able to really help these patients' quality of life. All right, so for the last, I think we have about 13 minutes or so, we're going to get into additional treatment considerations. I mentioned earlier, ocular sparing. I think it's important to keep that in mind in our glaucoma patient population because these are patients that are taking drops typically. And if we add more drops to their regimen, what's going to happen to compliance? I hate to have my patients being over inundated with a bunch of drops that they'll never remember to take. And so with my glaucoma patients, I really try to think about what are some other options I could consider to help their ocular surface, but not make compliance a hindrance for them. And that's really what this section, and as we wrap up, kind of discusses. So we know that inflammation is the hallmark of ocular surface disease. And we know we have good cyclosporins. We have, lifitegrast. I talked about corticosteroids. I used that earlier for a short dosage. These are great. They're drops though. And so, for our dry eye patients without glaucoma, I use these all the time. And at times with my glaucoma patients, I will as well. Autologous serum, we have amniotic membranes. But I want to focus really on kind of some of the ocular sparing options that we can consider for our patients that have glaucoma. Oral medications, don't forget about these. We have good oral medications such as doxycycline and azithromycin that work very well on patients that have meibomian gland dysfunction. And remember, a lot of our glaucoma patients have MGD or have meibomian gland dysfunction. I use a fair amount of doxycycline in my glaucoma patient population. You need to talk to them about the side effects, which is photosensitivity, as well as, stomach issues at time. But it's such a nice thing to add because many of these patients are already taking other things. It's an easy addition. It isn't a drop that you add. It's another addition to help to manage their lid issues that they're undergoing. This is a study that was published in 2015. Many of you have probably seen it. It's just really looking at doxycycline versus oral azithromycin. Why oral azithromycin? Because it's only a 5-day course. And so for some patients, and we talk about compliance, we talk about keeping the burden less, just doing a 5-day course of oral azithromycin in this particular study showed that these patients had improvement in their signs. And so both worked in the study, both doxycycline and azithromycin worked in the study. It's just that when you think of that short course therapy, azithromycin would be something to consider. Nutraceuticals. I think these still have a place and I utilize them on a daily basis with my patients that have dry eye syndrome, also that have, glaucoma and dry eye syndrome. I know the DREAM study shed some light that maybe they don't matter as much as we thought they once did. But I think there's still enough evidence out there to say, yeah, we should be considering these, especially omega 3s, omega 6s that are in a lot of these products. We have some products too that have this GLA in it. And there's many controlled clinical trials that have looked at supplemental GLA, again, a nutraceutical that's a lot of times combined with EPA and DHA to manage our patients or help our patients with ocular surface disease. And again, not using a topical agent and making the compliance a bigger issue for these patients. And then we have our in-office therapies. And yes, these cost money. These cost patients money typically. But again, sticking with the theme of what can we do to avoid having to dump a bunch of drops on our patients, but to still help them. And again, MGD is prevalent in this patient population. We need to at least consider these in-office types of therapies because, as you'll see here in a minute with the data, they're effective. Thermal pulsation. Many of you are familiar with this. Some of you very likely have this particular technology in your practice, which is going to heat and express the glands over a 15-minute period. Applying heat, manual expression. This is myself doing in a manual expression after applying heat. That feels so good when you do that. You're getting something done. A little nasty, I realize, but that's bad MGD. But boy, it feels good when you excavate or get those glands to allow that nasty meibum to come out. And so applying heat and then manually expressing to get those glands functional again, an in-office therapy procedure. And the data around these is good. These work. This was the Olympia trial. In this particular study, they compared the two technologies that we just looked at. When you look at the meibomian gland secretion score, within a 2-week period, we're seeing significant improvement with both technologies, and then out to a month as well. And so not only are they functional, but it happens quickly. And so we can give these patients hopefully relief a lot quicker than we could with some other treatment options. Again, I'll say it over and over again, ocular sparing. Try not to go ahead and put a bunch of drops in their eyes. This looks at the OSDI, the improvement in the ocular surface disease index in that same study that we just talked about. Taking patients with both technologies with an OSDI of 51, 52, severe level on the OSDI, and dropping that down to moderate, almost mild on their symptomology. So very, very effective in doing that, a significant improvement from baseline. And then we see a significant improvement in tear film breakup time with these two technologies as well at 2 weeks and then at 1 month also. Improving that tear film, improving MGD, making these patients hopefully less symptomatic. So improvement in signs and symptoms with both of those particular technologies. This is a handheld thermal pulsation treatment option. Some of you may have this technology in your practice where this is more you're treating sections of the glands. It's more portable. You get to visualize the meibum being released. You're applying the amount of pressure. So another technology. And again, the data impressive with this as well. This is just comparing two thermal pulsation technologies, the one earlier that we talked about, and then the most recent one here. And again, we're looking at OSDI scores. We're looking at tear breakup time in the middle, and we're looking at meibomian gland secretion scores on the far right. Again, both technologies improving. And these are in-office procedures. So yes, they're going to cost your patients money. But again, we're going back to that ocular sparing thought process. Neurostimulation. I think it gets talked about, but maybe not enough in our glaucoma patient population. Why I bring up neurostimulation is I would say I probably don't use this as much as I should in normal ocular surface disease, normal dry eye. But in glaucoma patient, it's a consideration. And why it is the therapies that I'm going to talk about, again, are ocular sparing. We're not having the patients have to put a drop in their eye. And so when we think about neurostimulation, we're stimulating the lacrimal gland by really the trigeminal nerve that is within the nose. And that's what you're stimulating. You're stimulating natural tear production for these particular patients. Two different technologies that we could consider for this. There's a drug-free option that's available that essentially the patient uses this technology and they rest it against the side of their nose, and it's got a small wheel on it that is stimulating the trigeminal nerve to produce tears. So it's an at-home device. The device is sold to the patient, and they utilize that to stimulate on the side of the nose there, the trigeminal nerve. And then we have a nasal spray that's available and on the market that the patient can utilize twice a day to stimulate the trigeminal nerve, again, to produce natural tears. We're not having to put a drop in. This is something that they can utilize on a daily basis as well. Again, going with that theme of ocular sparing with these treatment options. And then finally, IPL. This is something that we utilize fairly often in our practice. We actually utilize something called BBL, still another type of light. I'm really setting up tomorrow's lecture as well. I know for many of you, you'll be on tomorrow night, and there's going to be a full 50 minutes on the benefits of IPL. And I think IPL can be very helpful, again, for our glaucoma patients, sticking with the theme of tonight, because, again, I'm not sending them home to have to do a bunch of drops to manage their ocular surface disease. A couple different technologies out there. And what I really like is that we're getting more data on this. If we looked at this 10 years ago, even 5 years ago, there was maybe a handful of studies on it. But now you look at the literature and you look up intense pulse light, and we're seeing studies all over the place. And we're seeing that it's effective and it's helping our patients. And it's really decreasing in, inflammatory markers, and it's making, helpful with meibomian gland dysfunction. We've even seen some things around Demodex with it as well. But I think it's something that we have to consider because of its ocular sparing component to it and how prevalent meibomian gland dysfunction, rosacea even, is in our glaucoma patient population. So really, in conclusion and wrapping this up, ocular surface disease is extremely common in our glaucoma patients. It's easy to overlook it. It's very easy to overlook it because when we think of our glaucoma patients, our job is to do what? To prevent blindness. We don't want our patients to go blind. But as I mentioned earlier, and you think of those slides earlier, is a controlled glaucoma patient really one that has super red eyes, irritated eyes, beat up eyes, and a normal stable visual field, a normal stable OCT, pressures are great? Is that really a controlled glaucoma patient? I would argue no. We have to think about the quality of life with our patients as well, beyond just the intraocular pressure and those other tests. Be aware of BAK. BAK isn't bad. It just can be bad if we're stacking BAK on top of BAK on top of BAK, or you have a patient that comes in that is on medications already, or you're going to start a medication that already has ocular surface disease. Maybe consider a preservative-free latanoprost, or consider selective laser trabeculoplasty, or a drug delivery device, or just managing the ocular surface first before you start to initiate therapy. And then think about the alternate therapies that are available. Keep in mind that terminology of ocular sparing. What can we do to make sure our patients stay compliant with their medications?